Okay, so good evening, everyone, and welcome to the session. So, August is celebrated as Children's Eye Health Awareness Month, and to honor this month, OCI has brought this special webinar, on pediatric optometry. So, pediatric, ophthalmic surgeries, whether they are for congenital cataracts, strabismus, glaucoma, or any other ocular anomalies, they are the only beginning for a long journey toward the visual rehabilitation. And while this surgical intervention addresses the anatomical correction, it is the post-operative management and ongoing care that often determine the long-term visual success and quality of the life of the child. So this is where optometrists play a very important role. And from pre-surgical assessments, refractive corrections, and visual function evaluations to binocular vision therapy, amblyopia management, for caregivers, counseling, the optometrists form an essential bridge between the surgery and functional vision development. And their close monitoring and interventions are vital in detecting complications early, ensuring the treatment adherence, and also the guiding neurovisual rehabilitations. So, welcome to this insightful session, which will focus on a crucial yet often under-discussed aspect of pediatric eye care, the role of optometrist in managing surgical outcomes in pediatric patients. So, I would like to invite Ms. Savita to moderate the session from here. I'll quickly introduce her. She is a founder, director, and consultant optometrist of Eyeful Optometry Clinic, which is a unit Specialty Optometry Solutions Private Limited. She completed her graduation from Elliott School of Optometry, Shankar Nethralaya. She has been awarded Best Optometrist of the Year 2021 from Shankar Nethralaya, and she has also won the Best Case Report Award for the 2022 from OCI. She has been souvenired by Optometric Association of Tamil Nandbargal for playing a vital role in making myopia awareness video, which was released by the Health Minister, Mr. Ma Subramaniam. And her name has been also listed under the expert panel in drafting impact guidelines for myopia management by LVPI. She has her expertise in the field of myopia management, specialty contact lens fittings like rose scale lenses, scleral lens, orthokeratology, vision therapy, and occupational optometry services. So over to you, Savita.
Oh, thanks, Harshada, for that kind introduction. And I'm really happy to introduce Dr. Nulutparna Diori, one of the most skilled and trusted pediatric ophthalmologists in Northeast Asia. Believe me, I have just connected with her for one day, just one meeting. The knowledge she has is like immense. It is like flowing like a waterfall. You just ask her, she'll tell you whatever you ask her. So I'm telling you, this is going to be a blasting session. And she's the senior consultant at Arbor Vitae Eye Hospital in Guwahati, Assam. Formerly associate consultant and surgical training head at Sri Shankar Dev Nethralaya, Guwahati, Assam. She has chaired the Assam YOSI chapter, issue editor of Yo Times, and she has won multiple national and international awards, publications, presentations, instruction courses, whatnot. Her area of interest include progressive myopia as well as ocular genetics, and I'm sure this session is going to be a blasting one. And the meeting is all yours, man.
Thank you so much. I am really at a loss of words for such a kind introduction. It is an honor for me to actually share some little of my experience that I have in the field of pediatric ophthalmology. So, I really apologize for taking one day off from you because I was not well. So today we'll start the session as outlined before that we will be talking about the role of optometrist in pediatric ophthalmology. And before that, we will discuss a few common conditions, ocular conditions, but those will be just a gist of what we see, but I will concentrate more on pediatric squint as well as pediatric cataract, how we can move forward with these two. Other than that, I will take up any questions that you have, and we can have a very interactive session depending on that. Is it okay if I share my screen now?
Yes.
Okay. Is my screen visible to all of you?
Yes, ma'am. Yeah.
I'll go on slide share now. Okay. Is it okay?
Yes, yes. Yeah, perfect.
Something happened. I don't know.
Your slide is not moving, ma'am.
I'm not able to see my slide now. I don't know what did I think I don't know what I did.
Maybe you can stop sharing and then start the sharing again.
Yeah, stop sharing. Is it visible now?
Yes.
Okay. Oh no, something is wrong. Wait a second. Huh? So, the moment I
Harshada, in that case, if my doctor sends you the presentation, can you share the screen and do that?
I was about to tell that.
Yes.
Can do that. Yes.
Yeah. Doctor, if there is an issue with your,
no, it's okay.
yeah, can you just email it to Harshada?
No,
She can
it's
do the
okay.
screen share for
Is
you.
it visible right now?
It
Yeah,
is
Yes,
yeah.
it's
visible right
visible.
now, yeah.
Okay, then we will move. Is it moving? Just let me know. Is it moving?
No,
Not
it
yet.
is
Not moving. Yeah. Just give me 1 minute.
I think in screen share you have to select the whole this thing.
whole screen.
Yeah, whole screen.
Just 1 minute. Let me give it 1 second. Is it moving now?
No, ma'am.
It's not
Yeah,
moving now.
yeah, now it's moving. Yes.
Yes, yes.
Yeah, okay. So first we'll talk about some of the common eye conditions in children, and I do not share any financial interest for this presentation. So whenever we look at the patients who are in the pediatric age group, we have goal of examination is to evaluate the functional status of the eye and the visual system, assess the ocular and the systemic health of the child, and counsel and educate the parents, caregivers regarding the disease per se, and establish the diagnosis, formulate treatment, and then plan to go ahead. These are some of the external examinations that you would see in a child who presents to you in a circumstance like this in the emergency. This is another one. So there's a difference when you see these two children. One is presenting with a cellulitis and the other one is presenting with a neurofibromatosis. So the tensile condition of the eye with the cellulitis and the boggy consistency of the other and the shape of the eyelid determines that what is the ocular condition that you are looking at. Now, as as an initial examiner for yourself, you would like to be more concerned with the child, the girl here, with neurofibromatosis, because once that is treated or the ptosis has been treated for the child, you need to assess what is the refractive condition that she will come up to you. So although you know that amblyopia is one of the most common condition in these children who have a visual axis obscuration, so the post-operative or the post treatment management of the children depends upon a good refractive correction for these children. Okay. So here is another child where I just wanted to show you that children who presents with Downs may have a different variety of refractive correction, mostly going into myopia, and whether will you induce or include your myopia management in the children, and how do you seek to see the axial length elongation in the children, okay? This is another child who presents to you with an esotropia here because it is a manifest one in the child. But before you go ahead with the diagnosis of only an esotropia in the child, you need to look why the child is having that eso. Is it because of the, can you see the head circumference of the child and the condition in which he is sitting where he needs the support of his head? So you need to understand whether you are looking at some visual anomaly, which is because of the brain development or an insult to his birth history, or is it because of the cataract that is present in his eye? Similarly, children who present to you with this poking of your eyes, that is also known as it's just gone out of my head now. So in these children, eye rubbing or eye poking will give you an insight whether you are where you have to look at the IOP of the children, because the children then tend to have retinal detachments because of the poking of the eye, as well as they might have increased in the corneal readings in their steepest meridians because of the eye rubbing. So this is another condition where you see children presenting to at a very young stage, maybe 5 days or so, where they will give discharge, and do not come to the conclusion that you are seeing children who are maybe Rho plus positive, or you are looking at children who are having conjunctivitis at this stage. It can be ophthalmia neonatal also in these children, although it is quite rare because we don't use any more silver nitrate, but then these are some of the conditions that you need to look out for. This is another stage of decryosal. So these are some of the clinical scenarios that I'm presenting to you. Now, herein, this is a case of coloboma, although the coloboma is partial in this case, like the entire lid is not gone. It's a part of it. There is corneal opacity, and because of the corneal opacity, it does not exclude you from doing refraction in the child, because here you have to understand that the corneal opacity might will give you a higher amount of astigmatism, but then you need to correct the children. And following the restoration of or the reconstruction of the lid coloboma, the children again need to be refracted for their whatever astigmatism or the steepest meridian that you are looking at in these children. So this is another case of anophthalmos and complete coloboma. So by giving you these examples, what I want to tell you is that a general observation of the child is a must. Engage the child and the parent while doing your examination. Look at the alignment, where I have shown you a child who was not having a neck holding, was having an ESO, was also having a hydrocephalus, as well as having a cataract. Look at the motility of the children. The red reflex will give you an idea about it. Visual acuity wherever you can, and visual field where you cannot do a proper visual field, a confrontation test will also do. History taking, or what we know as the FAT scan of the entire family, that is the family album tomography, is a must while doing the history, taking the history, a family history of some disease that is present in all the family members, the presence of consanguinity, the prenatal history, the birth history is of utmost importance, as well as low birth weight or preterm in terms of ROP, onset laterality, and the progression of the disease at a child will come to you over a period of years, and also the developmental history of the children is important. General observation, as I have told you, what are his arm spans, what is his height, is there any winging of the scapula, is there any centurion syndrome, or is there a head tilt face turn in these children. So also other dysmorphic symptoms are also to be assessed in the children. Do not come to a conclusion without doing a proper general observation. So this is just to show you that you need to engage with these children. So this is a case where you will see here an esotropia. You might feel that the child is having an overaction of the inferior oblique, but that really depends whether the child can really move the eyes. So the motility of the eyes is important. This is a case of left hyper. So in these situations, when you are looking at a hyper, whether you are looking at a really looking at children who are having true hyper, or you are looking at a DVD, needs to be assessed by doing a squint evaluation for the children. So this is another where I really actually wanted to see whether the pattern in these children. So this is actually a pseudo strabismus, because as you can see, there is a larger the distance between the two canthi, and you can see there is a epicanthal fold. And once you do a pinch test for the children, you will understand that these are not actually ESO patients of ESO, but a pseudo esotropia. We see more in children who are in the mongoloid category. So you can also stumble upon children who gives you a vertical nystagmus, but sometimes in infantile cases, vertical nystagmus can be present, but and they wear off over a period of time. But while doing so, you need to have a neurological examination of the children. So these are some of the situations where I wanted to tell you that sometimes 9 gauges may not be appropriate for children and you may not be able to assess in them. So while you give them some activity and engage them engage them in your OPD, you need to see whether they have any head tilt, head turn, or face turn, or do they move very near or closer to the object of work. Okay. So this is, can we see the nystagmus in this child? Although she wants to focus on the artwork, but she's just moving her hand and not focused on the work that is given at hand. So regarding the red reflex, this is what we see as the red reflex. But when we talk about leukocoria, you need to understand that leukocoria is the yellow reflex that you see in cases of retinoblastoma, and the white reflex is where you see in cases of cataract. So the difference between these two can be appreciated in both the figures. The above picture is of a cataract and the below is one of a retinoblastoma. So the visual assessment, you all know, as per the child's age, we prefer the visual assessment. And in cases where you can see the fundus, it is good to see. And where you have patients who are presenting with squint, we look at the torsion. Now, when we look at the torsion, it is the imaginary line from the lower third of your disc and from the lower 1/3 of the disc, which crosses the fovea. If it goes up or down, depending on that, respectively. If it goes up, it is an intorsion, and if it goes down, it is an extorsion. So if the retina is not visible, we go ahead with an ultrasonography. And when we do an ultrasonography, we look at all the segments, whether there is any dehiscence in the posterior capsule, or whether there are any echoes in the vitreous, or are we looking at some coloboma or any staphyloma in the posterior segment. So this is another case where we are looking at actually an elongation of the eye in the posterior segment. So wherever you cannot do that, you assess visual evoked potential in the children. So examination under UA is done in children where they cannot tolerate the complete eye examination in the outpatient. So I'll not go into details of this, what we do in examination. You need to actually do all the examination in the children. Now, the timing of screening will depend upon whether you're dealing with some metabolic or systemic diseases, or are you looking at a child with ROP or retinoblastoma. And instrument-based devices only is better if the child is more than 18 months or the child has some developmental delay. And optotype-based acuity algorithm 4 years or above. Now, when I'm talking about optotypes for visual acuity assessment, now since it is the topic is that whether you will how you will help us in assessing the children pre and post surgery, or maybe post surgery in any case, be it cataract or be it children where we are operating for squint. You need to understand that the optotype that you are using should be marked. Why? Because in certain situations you use a Snellen's, in certain situations you use only single optotype or maybe a single row. If sometimes if you are using a crowded one and vice versa, in the next follow-up you are not using a crowded one but using a single optotype, you tend to either overestimate or underestimate the visual acuity. And while doing so, the surgeon who has done the surgery might think that, oh, okay, the vision has deteriorated or the vision has improved. It is not like that. It depends upon what optotype that you have used in your previous pre-surgery and post-surgery. You need to use the same optotype so that you understand that you are looking at the same visual acuity assessment pre and post-surgery. So the importance of it, I have just told you that the long-term consequences of amblyopia and strabismus can be serious in terms of quality of life, comfort, appearance, and career opportunities of these children. Therefore, it is a must to have all this examination. So this is the flowchart that I wanted to show you, that how we go ahead with this flowchart. Since this is recorded, you can go through this flowchart later on also. So supplemental testing only once you have assessed and diagnosed a case, and then parent followed by parent counseling, treatment, and management. And if there's no eye health or vision problems, you should go ahead with a periodic re-examination of the child as per guidelines, like once they completed 3 years of preschool, and then subsequently in yearly assessment. And also look at the growth spurts during 6 to 8 years, and then 12 to 14 years. These periods should not be missed. If there are some eye health or vision conditions that are diagnosed, treat or manage any of the conditions, be it acute or chronic condition, and finally schedule for periodic examination. And then coordinate with other eye care providers. Especially, we should form a team not only with the optometrist or orthoptist, but also with the parents in order to treat the children. So I'll not go ahead with common ocular disease. I'll just show you the pictures. This is a case of anophthalmia where there is congenital absence of tissue or ocular tissue in these children. But complete anophthalmia is quite rare. What we actually get is microphthalmia. And the treatment as the use of prosthesis in the children will depend upon the expanders. That is, how well you are actually expanding the orbit so that you can fix the prosthesis later on in the children. So another is microphthalmia. This is more common than a true anophthalmia. This actually is a reduced axial length of the globe, at least 2 standard deviation below the age. Now, there is always a debate as to what is an anophthalmos and what is a microphthalmos. But you have to understand that the nanophthalmos and the microphthalmos are actually the 2 standard deviation smaller size in the axial length or the size of the eye as a whole. But otherwise, what happens is that in anophthalmos, the sclera is thickened, the fundus should crowded disc, where there is vascular tortuosity, macular hyperplasia, and there's higher rate of intraocular complications in these children. Then coming to coloboma, the coloboma can be complete from starting from the iris up to your retinochoroidal coloboma. And sometimes you may only see part of the lens having coloboma there. It is not necessarily that every time you will see a keyhole pattern, but sometimes there might be some flattening of the lens with the zonules or without the zonules in these children. So this is one photograph. This is from the Google where I have shown you that the retinochoroidal coloboma below the disc. So this one. So in terms of the congenital anomalies of the cornea, we always follow the stumped mnemonics. And these are few of the cases that I wanted to show you where there is sclerocornea, where there is defective mesodermal migration during embryogenesis, and the peripheral cornea becomes more opacified than central. So in this situation, do you feel that you need to leave the child as it is? No. The answer is no. Why? Because even if the child does have a peripheral opacity, you need to refract the child, give him full correction, and then see if the child needs a low visual aid for his rehabilitation. So these are cases of Descemet's membrane injury or insult usually happens with the forceps, and these are more of vertical rather than horizontal. Infectious cases, these are herpes zoster and mucopolysaccharidosis. Peters anomaly can be present in children who has. Now, in these children, sometimes what happens along with the opacity in the cornea, that more often it is with the adherence of the iris to the opacity, you might also stumble upon a cataract. So, the preference is to go ahead with corneal transplantation and the cataract surgery. If at all in these children you prefer not to touch the cornea, sometimes it depends upon the decision sometimes is quite dicey in this situation. So if the visual axis is clear for the patient to have a good acuity for distance, better go ahead with the cataract surgery and reassure and counsel this patient. So when you refract these patients, look at the dilated as well as the undilated condition of these patients and see whether which will benefit him more. And definitely penetrating keratoplasty does help, especially the optical PK in these children. And also these are some of the children where definitely there is difficulty in telling that they need to go ahead with PK or whatever keratoplast, like corneal transplantation procedures. These are best treated once the diagnosis has been made. These are some cases of dermoid. Simple limbal dermoid are not much difficult to treat, but they can be treated. And once the dermoid has been removed, it is important that we do a good refractive correction of this children post surgery. So when you are looking at the dermoid, it is like you should not leave the patient, as I have told you from before, that when you are looking at a child, the general observation is a must, because if you have a preauricular skin tag also, you're looking at golden hair, and sometimes you may be looking at a child who has got a trichotillin or linear nevus sebaceous and Zadasone. So these conditions should be ruled out in these children. So on the other hand, if you have a lipoderma, all cases do not need surgical interventions. That is to be kept in mind. Although since the ocular surface might be disturbed in these children because of the presence of this lipodermoid, you need to have a clear ocular tear film in these children. So that way you really will be able to assess you need to understand that the tear film is the first refractive media that you are looking at. So if there is a disturbance in the tear film, the patient will keep on presenting to you with a lot of, especially the refractive problem in these children. So address that and then go ahead with the other treatment modalities. Similarly, there are conditions called as the vernal keratoconjunctivitis. There is sometimes overlap of the vernal keratoconjunctivitis and the allergic keratoconjunctivitis. In that situation, you have to understand that in vernal keratoconjunctivitis, it is the upper tarsus that is more involved. This is a red, itchy, and mucus production is more. And in case of AKC, these children do have atopic dermatitis and eczema, and they often accompany ocular allergy. So the particular attention to be given at first examination to the extent that sometimes the atopic dermatitis across the skin, elbow, neck, or canthus should be determined. And the severest form comes in the form of GPC and sometimes in the form of shield ulcer. So when you look at the difference between the AKC and UKC, you need to remember this difference and differential and table for both of them. The important thing that you need to understand is this involvement of the skin. The extra lid fold that is present should be looked at. So glaucoma, I'll not go much into it, but IOP measurement is one of the most important hallmark of glaucoma, as well as the corneal diameter measurement in the children. In children, The optic nerve head cupping as well as the corneal enlargement, Hebstria, and increasing axial length can occur within a period of weeks to months also. So therefore, uh, we really need to look at the this IOP measurements and the corneal diameter measurements of the children in a very rigorous manner, because optic nerve cupping in infants is reversible, and if you have diagnosed a case properly, it is the hallmark, and then you treat the children surgically or whichever surgically. The hallmark of successful treatment is looking at the optic nerve head, which has stopped in the progression. So another one is the Sturge Weber. So sometimes in darker skin, this is a lighter skin child where you can really make out that he has those portwine birthmark, but sometimes it is difficult to identify the portwine mark. So look carefully before you embark on just leaving out that, okay, everything is within the normal limit. So I have already talked about the other conditions, and these are synegia, where there might be congenital adhesion, sometimes because of cataract or sometimes intraocular inflammation. And in case of acquired cases, iridocyclitis and GI has to be ruled out in the children. So children who have hypoplasia of the iris can also have associated foveal hypoplasia with reduced visual acuity and early onset nystagmus. They have a lot of photophobia, and these children needs not only good refraction, but what kind of spectacles are you prescribing for the children? What is the hat that you are prescribing for the children is important, and it's quite important. So in cases where they have difference in the color of the iris, you all know this. So this Waardenburg syndrome is one of the most common, as well as the Horner's one that you need to rule out in the children. Regarding the cataract, these are some of the variety of cataract, congenital cataract that you stumble upon in children, starting from maybe nuclear sclerosis to the second photograph is actually the nucleus has actually reduced in size, and these are elongated this ciliary processes, and this is actually a case of PHPV. Can you see this blood vessel that is supplying nutrition to this area? And this is basically the part in the Burgess space, that is the anterior vitreous area. So you might have a microsphericphobia not in a singular manner, but sometimes you can have cases like this, which appear really unique in rarity. These are cases of JI where it has actually, there is seclusia of the pupil, and traumatic cases are very common. This is a case, as I have shown you before, of sclerocornea, but then might have associated cataract with it. So these are some of the cases which do not present to you early, but come to you late with absorption of the central nucleus. And sometimes these are posterior polar cataracts which present to you in an onion peel manner. But these are different types of cataracts that I really wanted to show you. So here when you take the history, you have to rule out those genetic metabolic diseases, even the systemic illnesses, ocular abnormalities, and maternal infection. These are the genes that are associated with different types of cataract. These are some of the classifications that we have used. These are zonular cataracts, total cataracts. These are anterior denticonus. These are pulmonata. These are PHPV. These are, I don't know, it was a pyramidal cataract and how it got like into a coralliform cataract. This sutural cataract, anterior as well as the posterior Y sutures, you can appreciate here. And you also, if it is a case of PHPV, you need to look at the strand of that emanates from the disc up to your what is the posterior surface of the lens in case of PHPV. So this was a gross case of PHPV, which is the photograph that I have shown you. Gonioscopy is a must for all of you to know, and also how to read the VP in these situations. the implantation of the lens in the children will depend upon the axial length, definitely not less than 19 millimeter, and also corneal diameter, which is not less than 9.5 millimeter or so. So the reduction or the post-operative refraction that you are looking at in the children will depend upon which type of undercorrection you are actually looking at, and it will depend upon your category of patients and also the IOLs. Definitely the IOLs, 3-piece IOLs are something that we prefer in children. And this is surgery. I will not go into the details of the surgery. And other than cataract in children, you can also stumble upon something known as ectopia lentis. If it is a gross amount of ectopia lentis, definitely the surgical choice remains your main armamentarium. But supposing you have a child like this, which do not have more than half or more than 1/3 of the pupil being excluded from the nucleus, from the lens, then you need to do a good refraction both in the undilated as well as the dilated condition, and then refract the child as for spectacle rehabilitation in the children as long as you can. But here you need to understand that you are not only looking at the luxation of the child, but also you are looking at the zonules, how they are placed, how is there any deposits, how much they have been pulled, and you need to keep a documentation so that you see in the near future in your follow-ups, is there any break in the journals or is there any lengthening, and so on and so forth. This is more important for us in the sense that we want to rule out conditions like simple ectopia lentis, microspherophakia, or maybe the systemic diseases associated with it like Marfan's, homocystinuria, Weill-Marchesani, Ehlers-Danlos, etc. So sometimes when we even operate the children and then leave them as such, the zonules tend to the zonules tend to stay the way they are. Herein, I had operated a child where I left the bag in situ, but it just remained as it is. So these are some other cases of, similarly, morning glory or other, sorry. These are some of the optic nerve conditions. Then in terms of retina, Coats disease, retinoblastoma, persistent fetal vasculature, this we have already discussed. So this is a case of Coats disease. It's a non-hereditary condition characterized by unilateral retinal telangiectasia, exudation, and exudative RD. This is a retinoblastoma. Now, we are looking at more of eye salvage in retinoblastoma. So while doing examination of the child, or if a child comes to you in this condition, you really need to understand that you have to diagnose the child at the earliest. Look at the photographs, previous photographs, if they are showing you, and the red reflex is more important in these cases. Going into details, this is a case of FEVR. This is a case of ROP. Yeah. Now, the importance of ROP is that once you have done an ROP treatment for the stage of the ROP in the children, especially if with laser or with intravitreal injections, the follow-up of these children is important because you are looking at the axial elongation of these children more in the posterior segment. So the routine examination should look at the refraction or the visual acuity of the children in subsequent follow-up, so that you refract them more often post treatment. These are cases of aniridia, definitely. So yeah, as I had mentioned to you before, if in cases of ptosis, now, in terms of surgery, when you are looking at a case of ptosis, you have to understand sometimes there is a dysgenesis of the levator palpebris superioris, and because of which you do not get a skin fold in cases of congenital ptosis. But sometimes when these children might have like a faint line of your palpebral fissure in this lid crease area, and you need to understand that not all cases will come to you without a lid crease. So you have to take into account the examination or the process of doing the ptosis evaluation in the children, where you look at the Bell's phenomena, you look at the jaw, if there is any association jaw winking phenomena in the children, if there is associated, where is how is the levator working. So all these things need to take into account. And when you are seeing these patients, because we all know that the lid does tend to give you the astigmatism at your on axis. So post-operatively also in the children, you need to take into account the astigmatic refraction in these children. So that is what I wanted to show you. So this is a post-operative photo. So another condition that you need to look at is this BPES, that is blepharophimosis. In these children, you get a inverse epicanthal fold. So these children also have a different refractive error, and like both because of the ptosis as well as the telecanthus and the inverse epicanthus inversus. So this is what I wanted to show you, the jaw winking phenomena. This child, open to child is present. So I had another video, but I could not present it. So similarly, the coloboma. So, this I'm not going into details now. So these are some of the acquired cases where you need to look at the previous photographs of squint in the children. And sometimes the squint can be congenital, or therefore the PET scan is important. So in case of infantile or in what we call as infantile esotropia, the theories include both a primary defect in the sensory development of the brain that leads to abnormal alignment and primary motor theory, in which the ocular misalignment is the primary abnormality. The diagnosis is generally made when an infant is present before 6 months of age with a large constant esotropia in full abduction, a normal level of hyperopia, and no underlying ophthalmic disorder that could lead to vision loss and a secondary strabismus. Now here you need to can just charger. So differential diagnosis, as I have told you from before, you have to pseudoesotropia, Duane's retraction, congenital six-nerve palsy, and early onset accommodative esotropia has to be made in the children, and also sensory esotropia and esotropia due to neurologically impaired children. So a complete examination, including dilated fundus examination. Mana itu laptop. Cycloplegic refraction to rule out possible early onset accommodative esotropia or a secondary strabismus is to be made. If any accommodative component to the crossing is considered to be a possibility, the child should be given the full cycloplegic refraction and reevaluated to look for any effect in the crossing. So this was a child with IDS. I wanted to, the video is not here probably. And I'll talk to you about the IDS, and also this is a case of strabismus pixels. I'll not go into details now. I really would look forward to some questions depend on the squint and the cataract part. This is a case of Duane's retraction. Look at the concentrate on the left down. And I did lower to see. Can you appreciate the retraction in the globe? Not on this side, but on the other side. So now when you are doing a squint evaluation, these are some of the points that from Kushner I am going to reiterate here. That if you stack two horizontal or two vertical prisms, the result is not the same as one prism equal to the sum of the two. Like if you have a 40 prism, you should understand that the 40 prism will not come from 20 plus 20. Either you have a 40 prism or you have to divide on both the sides. And the orientation of the back surface of a prism to the patient's face will affect its effective power. Therefore, the prism has to be placed in the frontal plane. And whenever there are children who are having a high power spectacle, especially more than 5, will induce a prismatic effect over a deviated eye that requires an adjustment of the value measured with the PSCT. And also, when we do surgeries on oblique muscles, especially like superior oblique tuck or especially like cases also, it will definitely alter the axis of astigmatism, and therefore the change may be permanent. And in the children, even if you get an axis preoperatively, say around in a different meridian, you have to take into account that post surgery of these patients who are who have undergone oblique surgery, the axis might change. So this is what I wanted to tell you, that stacking two prism does not give you the same prismatic effect. Can you see the difference of the deviation through the prisms? And second is, if you are not placing it in the frontal plane, even the deviation shifts. That is, the image shift is there. And children who listen to you with high spectacle power or hyper spectacle, you need to consider that these causes some amount of induced prismatic effect when you are doing the evaluation over the glasses. So this is a child that we evaluated. So without the glass and with the glass, you will notice the difference of the image shift when the child is wearing the glasses. So this is the 9-gaze evaluation. These are just a pencil test stirrups. Look for the torsion, and then we go, even a spectacle correction might help in the children. So treatment is performed after any associated amblyopia, if present, is treated. And in case of strabismic amblyopia, sometimes the surgery is preferred prior to the amblyopia treatment. But the primary goal of treatment in congenital esotropia is to eliminate or reduce the deviation as much as possible. And ideally, this results in normal visual acuity in each eyes, straight-looking eyes, and development of binocular vision. The prognosis is that even with successful initial treatment, many children with a history of congenital esotropia may redevelop strabismus or amblyopia, and therefore need to be monitored closely during the visually immature period of life. So this is one case that I wanted to show you. This is the picture of another patient but had undergone similar MR recessions. So the important thing that you need to take home as a take-home message for esotropia is that it is intimately linked to both accommodation and accommodative convergence. So the importance of doing an AC by A ratio is of crucial importance in treating these children. The full amount of hyperopia as well as the AC by A ratio estimate is to be done in all forms of esotropia. And all children with ET must be refracted after full cycloplegia. Atropine is good, but if you're not using atropine, you need to understand the cyclopentolate that you are instilling in the children. Either it should be at least twice, or if it is of a stronger strength, then it should be only once. And cyclopentolate usually takes around 40 minutes for its effect to come. So what you can do is that you either do an additive effect with tropicamide. But you need to understand that tropicamide does only the dilatation. It is the cyclopentolate that will cause the cycloplegia, and you have to reassess only after full cycloplegia. Refract often. This goes without saying that you really have to refract as you follow up patient on follow-up to prevent any deterioration in the alignment or recurrence of amblyopia post-surgery. In children with a high AC by ratio, use a wide D segment bifocal, and the preference is usually around plus 2.5 diopter. And the frame selection is very important in the children so that you have a wide D bifocal. It is a wide difocal gives you a smaller, less thicker. I'm using the term less thicker than an executive bifocals in the children. As you go by treating in this children, you can do the bifocal segments, cutting the pupillary axis or below it accordingly as you follow up this patient. The qualitative assessment of AC by A ratio, be it gradient or the heterophoric method, will depend upon whether you are using a over plus or a over minus while measuring the AC by A ratio. And the optimum timing for any surgery in these cases will depend upon a full hyperopic correction for at least a month. Amblyopia has been overcome by the child, and the measurements are accurate and stable on subsequent visits. In On the other hand, when you are looking at I have not gone into details of all the forms of exotropia. If you're looking at an intermittent form, which is more commonly seen, it may begin as a latent deviation exophoria, and that over time it deteriorates into an intermittently manifest deviation. So, but you have to understand that when they are alternating, if there is no alternation, it does not confirm that the amblyopia is present. Okay. So even if they're not alternating, do not think that the amblyopia is present. These children do have good visual acuity. Photalgia, which is known as the bright light increase, just the fusional convergence amplitude in patients with XT may persist despite successful surgical intervention, and it has to be told to the patients before the surgery so that they are prepared after the surgery that the photalgia might be present. Okay, so this is just I wanted to show you like how you determine the thing. So one last point of take-home message is that all patients with XT who are undergoing surgery should have a measurement made at 6 meters after 45 to 60-minute patch, or have a measurement made while they fix at a far distant outer target, regardless of their distance or near classification. Why? Is that because both of them are not interrelated and they do not compensate for each other. You have to understand that there is a difference of at least 30% when you are measuring these children when they're looking at a very distant object outdoors, or where if they're looking at a 6-meter distance, there is a difference in the magnitude of their screen. So the decision when we are doing the surgery for these children will depend upon whether to begin or change treatment is by the frequency of the deviation, and is how much time it is present, and the magnitude of the deviation. The magnitude of the deviation will influence only what the treatment should be, because we have already determined the treatment wherever it is indicated. So it will only determine what treatment should be, like recess resect or bilateral recess, depending on the. And studies have shown that surgery in very young intermittent exotropes is more likely to result in subnormal fusion than when surgery is done at an older age. And we see that in cases of intermittent exotropes, sometimes they have such good control, visual control, that they tend not to, we do not even go ahead with surgery, even with a high amount of prism deviation, even in the later stages of their life also. This is the actually differentiation classification of Burian and Kushner. We follow the Kushner classification for intermittent exotropy, especially for surgical combination. And this is the classification of control of intermittent exotropia by Kushner. Along with the intermittent exotropia, you also have one more point that you need to understand in this treatment is the convergence insufficiency. There are two grades of convergence insufficiency, one which depends on the fusional convergence, and another one is the accommodative component of this entity. Now, fusional convergence insufficiency is characterized by minimal or no exophoria at distance and a somewhat larger exophoria at near, which in some patients may be an extreme, and they respond well to fusion convergence orthoptic exercises. So where you want to give the exercises will depend upon if you have really diagnosed these cases of convergence fusion insufficiency. Next is the accommodative convergence insufficiency is characterized by manifest XT at distance, either an intermittent or less frequently constant, and a larger exodeviation at near. So these patients usually do not respond well to surgery, and they are poor responders. So this is nystagmus. I'll not go into the nystagmus much. Just showing you some videos of nystagmus, on this deprivation, on this neurological. This is not the nystagmus, but the hippas. This is a slow circuit. So these are some genetic conditions, so I'm not going to. And then comes the impact of high myopia. Savita has done a lot of work on this. I'm not going into details of it. But this was when we thought that by 2050, most of the patients are going to be myopic, but we are at present looking at 2030. And these are some of the changes that happens in a myopic patient. Why we are concerned is because of this high myopia conditions that affects the retina and the optic nerve. And no, this nothing. These are some of the cases that you might cover. So I would like to thank my mentors, my previous place of work and my current place of work, and the consensus that we have taken. This is some of the references. Kushner is another reference that I will tell you. So thank you so much for your patient hearing. I would like to take up questions.
That was an extensive presentation, ma'am. I think uh, if the participants have any questions, you can put down in the chat box, or it's a very close group. I can take the questions for a few and then ask madam regarding the same. Meanwhile, I have few questions. Maybe I can ask you, I guess. Meanwhile, when the participants are typing. So when it is sclerocornea, where the peripheral cornea is not that transparent and the central cornea is transparent, what will be the conjunctival, how will be the conjunctiva? Will it be very soft, or whether it will be associated with any, micro cornea, or how it will
You
present?
see more, because the transition is so smooth over from the conjunctiva up to the cornea.
Mm.
Herein, it is a sclerocornea. So the sclera actually transcends into the cornea. So in these situations, you will see more often that the cornea is more flat rather than it is difficult even for you to with a handheld keratometer also to even measure, because the cornea seems to be smaller than what it is. The white to white measurements in these children is very difficult because the transition has gone over the cornea. So the conjunctiva per se will not differ as much, but sometimes you see more pigmentation in and around the
What
area
is the
of.
cause for the sclera to, come over the cornea?
So these are cases where you see that I have already told you. Sometimes it is the genetic conditions that manifest as such, where you see that the uh, uh, that is a 22q11.2 deletion syndrome are there in these children. So the mesodermal, what happens is that when the mesoderm is migrating during the embryogenesis, there is a defect in the mesodermal migration. So when there is a difference in the mesodermal migration in this children, the mesoderm forms the scleral part, so it just overrides it. So more of a thing like that.
Okay. Thanks a lot, ma'am. And I have one more question regarding ROP. So I had a patient like in between who was like, high myop, around 13 diopters. ROP kid, now he is around 10 years old. His mother usually says that the ophthalmologist has told him that ROP treatment has been already done, that laser has been already done, and then he will not end up with RD. And then this was she always says whenever I ask her to go for an ophthalmology opinion, you know.
Okay. So
So
when
is that so? When laser is done
yeah,
for
yeah.
ROP,
So since
will it?
laser, while doing laser for ROP, we usually laser out the
Mm,
peripheral retina, right?
mm,
So what happens is, in simpler or in layman terms, you can say that the area has been lasered, or we have created an adhesion, okay, so
okay.
that the retina does not detach. Even in say barrage laser or in PRP, what we do there, definitely the pathophysiology of doing that is different. Like you are creating anoxic area, hypoxic area, all those terminologies are there. But just in just layman term, what you are doing is that you have reattached it. So when the parent is telling you that laser has been done for the ROP child, but the child is in myopia, right? In high myopia, you might think that the patient will go to RD, but since the peripheral retina has already been lasered, so probably she has been counseled that you need not worry about it. So that was
Okay.
the reason I was telling you that children who have undergone laser or maybe intravitreal injection, this history has to be taken when you are treating a child with ROP. Because on subsequent follow-ups, when these children grow, see, already they are preterm. Their capacity to catch up with their peers is much more higher than a normal child that is growing, right? Even the eye elongation, because you have already lasered that area. If you have done laser, the elongation of the eye in that area becomes more. So sometimes the posterior segment, in some articles it has been mentioned that the posterior segment grows more than post-equatorial than the anterior segment. You cannot have the AC depth increasing or the lens going behind and all this. You understand what I'm saying? Like if you club the eye as a whole, in axial myopia, the the way the axial myopia grows, have you seen the posterior segment keeps on growing, no? So in children who have undergone laser in ROP, the posterior segment tends to grow more. That is why you have done ROP, so you leave the child is okay, comes back to you at 6 years, 7 years, and you do the reflection. No, you have done the child comes back 1 year, see, 2 years, see again, 3 years, see again. These are not normal children. These are not like normal children growth. And along with that, we already know that myopia is multifactorial, right? Even the genetic WS studies have shown that this is multifactorial, which very point. So if the child is ROP treated with laser, you already have a predisposing component. Then again, inevitably, if the child has parents who are myopic, so looking at multiple risk factors for the child to grow into myopia. So why are you not looking at the child when the child has already completed 2 years or maybe 1 year when you were doing the refraction in these children? So when I mentioned the EUA, I did not show you the entire thing, but I told you that even when we are doing an examination under anesthesia, it is important that you complete the entire examination process, starting from the refraction to the fundus examination, to your corneal diameter, to your bone square, everything. To the head circumference, looking at the child is a general observation, it is important. Treating a pediatric child is not treating only the refraction of the child. Treating a pediatric child is a holistic approach to the child.
So, if the participants have any questions, I can take it. Ma'am, in cases of bilateral cataracts in infants, how do you decide between leaving the child aphakic versus implanting an intraocular lens?
Yeah, I think that day we had a long discussion on this. Yeah. So you have a child with bilateral cataract, even if it is unilateral also, but the question has been made simple for me since it's a bilateral. You operate on both the eyes, you want a binocular vision for the child. And as I have told you in my slide, that the corneal diameter as well as the axial dimension, that is the size of the eye, should be according to the normative age of the child. That is the normative data. If it follows that you are having more than 19 millimeter of your axial length and you have a corneal diameter which is more than 9.5, you have IOLs nowadays which can snugly fit into a bag of that capacity. Okay, so these criteria has to be met before you embark on putting an IOL in the children. So sometimes this criteria is met even in children who are 3 months old, sometimes 6 months old, sometimes it is a little later. And as I have told you that you need to rule out the systemic diseases in the children. If you are having a child who has got rubella does not necessarily mean that the child will have only one eye affection. Sometimes it can be both eye affection also, but both eye can be smaller. And sometimes it is, if one eye is affected in the situation, it is difficult to treat in these children. But supposing you plan that this criteria is not met, you have to understand that you need to leave the child aphakic. And when you are leaving the child aphakic, as I have told you, that when we are treating a child, it is a team effort, both from the doctor to the anesthesiologist, to the OT staff, to your orthoptics, to your optometrist, to the parents. If in this whole team, if any of the factors is deviating from the SOP, then you have a problem here. So in this entire team, the most important or 80% of the work is done by the parents. Your job is only 10 to 20%. So if the parents are not compliant with with putting in post-operative contact lens because of the aphakia, then you are again looking at dense amblyopia, because congenital cataract is a case of dense amblyopia in the children. So if you feel that no, it is not going to be, even if they're not wearing, prescribe the spectacles, prescribe the high bar spectacles, no issue, but you have to give him a visual rehabilitation in the children. So the decision for us, whether we will be giving IOL or we won't be giving an IOL will depend upon the physiology of the eye of the child at the point of time, and also the anesthetic complications, if any, for that matter, number one. And number two, as an optometrist, you have to understand what we have done for the child and how you are going to visually rehabilitate the child for that matter.
One more question, ma'am. Like, given the growth of eye over time in kids, how do you calculate IOL power? Is there any available formula to adjust the,
Yes. Yeah, I
IOL?
have already shown you. There are different formulas that we have Dahan and Rastio et al, Trivedi et al, and Eniadi et al, and rule of 7. There are different formulas. Most of us prefer that rule of 7 is good for children. And sometimes some prefer that they want to have a post-operative refraction, like a hyperopic refraction of maybe +6, +7, according to the age of the child, like from 2 years, and so on and so forth. But in my experience, what I have done over the last years of my experience, I have found for me the Han et al classification was little better for me to look at the children. This undercorrection formula actually depends upon the percentage reduction of the IOL calculation. That is a 10% reduction or a 20% reduction, and accordingly, postoperatively, am I looking at a +1.5, +3, or a +6 diopter postoperative refraction of the child? One, that is the classification system that you want to use or you can use for your child. So if I don't tell you which system I am using, then postoperative, when you are doing the refraction, you have a surprise. And you feel that, oh, the biometry went wrong or this and that went wrong. Actually, it's not that. Before calculating your formula, you are actually looking at the biometry. So the biometry has to be consistent. A consistent person has to be doing, or you yourself has to be doing it. What type of biometry are you looking at in the children? Is it the optical one, wherever it is possible? If not, then are you using the ultrasound? Are you doing an indentation of around 0.1, 0.2, whatever? And are you taking into account whether you have, for the indentation that you have done, or are you using an immersion technique where there is no indentation? So whichever formula you are using, whichever method you are using for calculating the axial length in the children, compare with the other eye. How's the growth of the other eye? Is the other eye okay? Is according to the age, or does that eye also have got some refractive error, or does that eye also is developing cataract and will need surgery later on, or that eye is normal? So that that will give you some amount of indication that you are doing. Supposing you have a child and you use a percentage formula, like, okay, I'm going to do a 20% undercorrection for the child, and you end up with a +6 diopter in one eye. So probably that patient had a like a monocular cataract, right? Now the other eye is normal. So you are looking at image distortion in both the eyes with a difference of +6, right? So that is a huge difference. So will you actually do a +6 postoperative hyperop in this child who is around 6 years or 7 years? You might not. In these children, it's better go ahead with the emmetropic correction because he's already in his growth spurt area, like 6 to 7 years. So don't do that. Even for children who are 6, and sometimes right now we have different ways of calculating. Even if they're 5 and having a good axial length according to the biometry, then you might implant a emmetropic correction in the child, and then if you see that postoperative these children are having a myopic shift, you treat it accordingly with spectacle. This happens more so in patients who are a little older. They have given an emmetropic IOL implantation in the children, and then they end up with a huge myopia postoperatively in cases of trauma, unilateral trauma. Like the injury might be very less in the cornea with not too high astigmatism, say around maybe -1 or so. But then because of the trauma, the child had a cataract, you implanted an IOL, and the child is now coming to you with high myopia, like a minus difference. So there you need to be a little more cautious. So things like that do happen. We do have sometimes refractive surfaces. But the question which you had asked for bilateral cataract is definitely I will look at the normal physiologic growth of the
Physiology.
and the anatomic growth of the child, and then decide for implantation of the IOL.
Ma'am, if for the sake of audience, like maybe most of the optometrists would be practicing with the ophthalmologist. So, if at all you can share the, I mean, the percentage data, what you have said, like for the IOL
Yeah,
calculation,
I have that. I'll share it in the maybe in the
chat box, or
yeah, or maybe
or you can
WhatsApp,
send
or
us.
you can just take it.
Yes, we can share it with them. So that will be more helpful. And one more question from the participant. How do you decide between unilateral and bilateral muscle surgeries in strabismus?
Yeah. So you see, so when we are, as I have told you previously, that when we are looking at the squint evaluation, I had told you some take-home messages in the squint evaluation, right? So in that scenario, I had told that when we are one second. When you are doing a squint evaluation for the children, what we tend to forget is that how we are holding the prisms while doing a squint evaluation, because this itself will give you an idea that the amount of image deviation that you see, right? Or the eye deviation that you see, and then you do your PACT or PPCT in the children, cover test in the children. So if your calculation is such that you have come up with maybe 30 prism in a child, but then because the way you are holding not in the frontal plane, or if you're stacking up 15 and 15 and giving us a different distorted image, so what happens, we tend to end up with a different undercorrection or overcorrection in the children. Okay, so that is the prism that you are using. And if the child has a high power lens, maybe spectacles, maybe a plus more than 5 plus minus whatever, so that will also give you a prismatic effect. So it calculate the deviation with and without, and see it is with. And then the AC by A ratio. AC by A ratio is important both in cases of esotropia as well as in cases of exotropia. Now, when you are looking at a high AC by ratio, are you looking at a convergence insufficiency, or are you looking at accommodative differences? So that is why I kept a slide extra, like the convergence insufficiency is one component that you need to look at when you are seeing a patient with intermittent exotropia. Okay, that component I had kept in mind. Second is that infantile esotropia. All cases of infantile esotropia also do not require surgery. We follow them up. And the optimal time of surgery, whether 6 months or so, how is the growth of the eye, all these factors come into play. Now, the question that you asked, whether I will go ahead with a single muscle or multiple muscle or a double muscle, will depend upon the amount of prism deviation that you have already given me, or what I have calculated after doing the squint evaluation, keeping in mind how I have placed my prism, how I have done my prism cover test, right? Whether how I have neutralized. So depending on that, the maximum deviation, whether it is for distance or for linear, depending on that, we calculate and we do for a muscle surgery. So usually what happens is that rather than single muscle surgery, what we are looking at, single eye surgery or bilateral eye surgery, that is what we are looking at. In situations like, for example, you have an exo, I would prefer to do a bilateral LR sessions, dividing the amount of prism that deviation that you have given me within the muscles. So that calculation, as I have told you, similar to the IOL power calculation, similar to that, we go ahead with the muscle, what is that calculation, that for this much millimeter of muscle recession of the LR, supposing of the LR, I am looking at this much amount of prism deviation.
Prism correction.
Right? So for example, I'm looking at a 3 millimeter or 1 millimeter to a three prism diopter of correction, right?
Okay,
So
1 millimeter to 3 diopters.
so say I'm doing a 6 millimeter or 8 millimeter, accordingly I'll calculate. Okay, no? So if I'm looking at a 8 millimeter, 24 prism correction with a 8 millimeter, so bilateral will give me how much? Around 48 or nearing to 50. But again, as I have told you, this is a surgical procedure. For every surgical procedure, every person has their own way of calculating that. How much tendons are you looking touching? How much amount of muscle you are stretching and looking at before putting in your sutures? How much stump of the muscle you are leaving? Are you putting your sutures at the sclera? Are you are you doing a hang back with only the sutures? Are you doing a hemi hang back? Or are you actually doing a posterior fixation? Have you actually done a posterior fixation suture? So sometimes what happens is that recess resect processes happen in sometimes in one eye only. They're looking at one eye recess resect in that situation. You do only one eye resect. So, in most of the cases, when the visual acuity is less, the age is more, we do only one eye. But usually it is better to divide in both the eyes, considering the work of the yoke muscles as well as the laws of Herring and Sherrington and all the laws that govern the ocular movement. And also you need to understand that post-surgery, how are you looking at if it is a isotrope or an IXT that you have measured? Do you really want to keep the child like not converging post-surgery? Or if you want to converge the child post-surgery, you don't want to like before your measurements, but you want the convergence to still persist for the child, or sometimes you do a little overcorrection like that. So how can I explain all this? So things like that when you do, so we do certain mechanisms of like placing the muscle like a tendon down, like the lateral rectus or the medial rectus, a little up and down, creating a pattern, V pattern post-operative. So things like that do happen. So as an optometrist, when you are evaluating, you have to look at one point that if there was a posterior fixation suture also placed in the muscles, like you have placed the suture, posterior fixation means you have placed a suture at that point from where you want the muscle to work, right? So in situations like that, you might feel that there is when you look at the extraocular movements or when you are refracting movements, you might feel that, oh, the eye is not moving in the direction, or there's some restriction, or FDT, something is wrong. But no, actually it may not be that situation. It may be that you have not read the operative note properly. Sometimes that also does happen. So things like that. So the decision to do surgery on one eye will depend upon the AC by ratio that you have calculated, the convergence of the patients, and also if it is a huge large angle, better for us to use like both the eyes bilaterally. If you can divide the
prisms.
yeah.
One more quick question, ma'am. Of the images you have showed us, what are the conditions like where you will, prefer contact lenses than, you would be trying for surgeries, or, maybe I have seen few conditions like, lid coloboma. I thought like a contact lens would be a greater option for that. Scleral contact lenses. So in the pictures you have shown us different types of, pediatric, ocular conditions, not only coloboma, other ocular conditions. So what are the conditions you think like contact lens would, do better?
See, in definitely high refractive error is a condition. Second is both in terms of spherical as well as your cylindrical. In case of keratoconus, definitely that you are doing more of that work. High myopia, photokeratology also works, and even larger contact lenses works better even for keratoconus. In children who have nystagmus also, sometimes it is seen that contact lenses do dampen a little bit of nystagmus.
When the power is high, when the refractive error is high, contact lenses too. I do agree.
But I would definitely want to learn more from you, where in whichever more conditions.
Yeah, I have seen two pictures like where this eyelid coloboma. I was like thinking maybe if there is any damage, you can do an trassorrhaphy. Whereas the picture you showed me, it was like there was a total loss of eyelid.
Yeah.
I do not know whether you
The
would be
central
preferring an
portion was
amniotic,
lost.
to preserve the cornea, whether you will be preferring an amniotic, surgery, or like, a scleral contacts which can protect the cornea for a long time.
Although
Uh,
you will see that in that photograph, I had shown you the upper lid coloboma at the center, but the opacity was down.
yeah,
So so that is why when I was talking
might be
about
while
the
sleeping,
screen,
the lid may go up. Upper cornea is getting covered, but the lower cornea is
no,
getting exposed.
yes, so that is why I told you all that during the ptosis evaluation, it is
Pupils.
important that you are not only looking at the crease of the eyelid and just writing that it is a case of congenital cataract or congenital ptosis. Look at all aspects of ptosis
Aspects.
evaluation. Similarly, in these patients, although this patient is not a patient of ptosis, has a lid coloboma, but the entire upper cornea or the upper two-third of the cornea was spared. Nothing happened. This is a older child. Had it had something affected, it would have affected long back, not
Long
now.
back.
Long back, because he is colobomatous from childhood. But what was affected was the lower cornea. So what happens when we see children like that, even in the periphery, as general practitioners also, our first thought comes to the mind that, oh, the cornea is exposed. So we give a lubrication, lot of lubrication. So during daytime, the patient is spared. But
Night.
during nighttime, it is what it happens. That is the situation.
In
But
these cases, like
definitely,
what, when there is a lid
yeah.
problem in terms of contact lenses, scleral contact lenses, we advise two lenses actually.
Mm,
One in daytime and other in the nighttime. Like they'll,
okay.
because they, yeah, so
Mm,
they can wear, because there is going to be a bowl of saline. So that is
mm,
going to preserve the
mm,
protect the cornea. So
okay.
what we advise is like one lens can be worn in the morning. That can
Mm,
be disinfected in the nighttime, and then
mm,
nighttime they can wear the other lens. So this is
okay.
how we advise.
Okay. Okay.
And
That's
also
a
in the
good
cases of, I'm not
information.
sure whether for sclerocornea, even scleral lenses, because most of the opacity, corneal opacity conditions, like when we, but that is because of the exposure that happens, the
Mm,
cornea becomes opacified. I'm not
mm,
sure here how it will be working on sclerocornea, because as it is a mesodermal defect.
mm,
Uh, but most of the opacification is getting better with the scleral lenses. And we can customize the scleral lenses sizes also.
mm.
Not
So
sure
I
whether
think
it will be
probably in this
useful for
patient,
sclerocornea. I just thought I
mm,
will take your opinion.
no, that I think we can think about. I'll go through the literature more about it, but that is a very good suggestion that you have said. And these cornea, definitely you'll have to customize because they're very flat,
Flat.
so, flat ones.
We
And
can customize cornea. And there are also scleral lenses where we have fenestrations.
oh,
So
okay.
that can be worn for a longer time, actually.
Mm-hmm.
I
Okay.
think those technologies should come into India more, and then more patients should be benefited.
I definitely would love to know more about contact lenses from you. I'm learning today a lot.
No, we are learning so much from you, ma'am. I think if there are any more questions, yes, there is one more chat, I guess.
Okay.
No, there are no more questions from participants' side. That was greater learning from me, for me from you. So happy to be a part of this session. Thanks to CA, thanks to ma'am. It was a greater learning for us, and looking forward for more and more sessions from you in future.
Yeah, thank you so
Thanks.
much. Taking one topic is a little easy because then we can go into in-depth of that topic. But as such, for pediatric, if you do not know how to approach a child, and especially even from the infancy up to the entire general examination and everything, if you that was the reason that I wanted to show you a little bit of the general things that we see, and then we embark on it, because all cases that come to you, we do not go for surgery. So it really is not like I do a surgery and you follow it up for us or something. It's not like that. Pediatric is a teamwork from the very first, I have told you. So, and you need to understand for the surgical aspect, especially the squint and the cataract, like what I have done, what undercorrections I have done. Even for squint, if I have done an overcorrection of 10 prism or so, is it normal? Yes, it is, because 5 to 15 prism we consider as normal postoperatively, because there are drifts after a few years. and how we follow them up. Do these people who have insufficiency, I told you that accommodative insufficiency will do very bad with surgery. Convergence insufficiency, do they need bifocals post surgery? How was their AC by A ratio previously? So those things needs to be discussed in details and needs to be seen, like as I have told you about photalgia and all this, when we measure their deviation in the daylight, when they're looking at a distant object, or when we are measuring it within your what should I say, within your office, within a 6 meter, there occurs a lot of difference in doing that. So these are some of the smaller things that we learn from our teachers, and which we tend to percolate through our team of ophthalmologist, optometrist. So, but then probably we'll need a longer one topic longer session probably.
Yeah. I think to sum up, like from whatever you have said, from our point of view, to assist you for a better surgery,
Yeah.
I think we should be doing a good refraction. That is the first and
Yes.
major, most important
Most
thing.
important.
Most important thing. And be thorough with your binocular vision assessment,
Mm.
especially your AC by A ratio, which is
Yeah.
again a crucial thing. And be thorough with your, PBCT, how to place your prisms properly when you measure. And when don't stake too much. When you stake, you will end up with different prism evaluation.
And
And
never
then
stack. Never stack.
yeah,
It's a very simple physics experiment, no? Never stack.
no, that was very nicely shown with the pencil also. So we could easily
You
relate to
can
it.
just see the image displacement. It's a
Yeah.
very small thing, but as one of the questions was asked, how do you determine how many muscles? So supposing you give me a smaller one, and then I said, okay, let me do one muscle. And then I end
Yeah.
up, oh, no, I had to do two muscles because the
45 prisms,
it
what
was
to
not
do? There is no
placed
space for
properly.
me.
Yeah.
Okay. Okay, I understand. So PBCT is again very important. And maybe post-operatively, again, measuring the accommodation, and then wherever needed, we can give vision therapy, or, spectacle correction. And I think one more thing which I forgot is filters. In case of colomamas and things, we can try off different filters, and then
Yeah.
um do a better
Contact
rehabilitation
lenses.
for that patient.
And also
And
contact lenses, you said about
yeah,
contact lenses.
yeah, as a contact lens person, I should not do visit. Yeah. So
Yes,
wherever needed, the
very,
contact lenses.
yeah, she
So,
very rightly said that it's a teamwork, whether it's an ophthalmologist or optometrist,
optometrists, exactly.
teamwork, and that will give us the better outcome, yeah, in pediatric patients. So thank you
Yes.
so much, Dr. Nilutparna, on behalf of the whole OCI team. And of course, all the participants, I extend our heartfelt thanks to you for your, such valuable insights. And thank you once again for your time, dedication, and helping us strengthen the basically this bridge between ophthalmology and optometry for the
Optometry
benefit of our pediatric patients.
patients.
Yes.
Thank you so much. It was such an honor to be with you all. I do not have much experience, but I tried to share as much as I could, and I hope it was a little bit beneficial for all of you.
It was definitely, ma'am. Thanks a lot for your time.
Thank you so
Thank
much.
you, Savita, for your time. Thank you so much for monitoring
Thanks.
this.
Thanks, OCI, for the opportunity. Thank you.
Thank you. Bye bye. Good night.
Bye. Bye.